Okay, so in the interest of time, I'll go ahead and get started. Good afternoon, everyone, and welcome to today's webinar, our Let's Talk NMD webinar. And today it's a webinar called Pompe Disease and You. We have Dr. Mark Tarnopolsky here to give us this talk and answer your questions on Pompe disease. Dr. Tarnopolsky is the professor in the Department of Pediatrics and the division head of neuromuscular and neurometabolic disorders. He is a graduate of McMaster University and has been a faculty member since 1996. Dr. Tarnopolsky focuses his innovative research on mitochondrial diseases, muscle disorders, and other neurometabolic disorders. His goal is to discover and evaluate therapies and treatments for people with neuromuscular diseases, mitochondrial dysfunction, and other mitochondrial conditions, such as aging, immobility, diabetes, and obesity. In addition, he holds a chair in neuromuscular disorders from McMaster Children's Hospital, Hamilton Health Sciences Foundation, and is recognized as an international leader in researching neuromuscular and neurometabolic disorders. Earlier this week, Dr. Tarnopolsky provided a great webinar for clinicians, academics, and researchers across Canada on Pompe disease. And we invited him today to give us a talk for individuals impacted, their family members, advocates, allied healthcare professionals, and policymakers. So we're really grateful to have you again today. Thank you once again for your time, your expertise, and we look forward to your talk. Over to you.
Thanks very much for the kind introduction. We'll go through things and try and leave at least 10 minutes at the end for questions. Things that are pretty straightforward, I will go through quickly, and then we'll stop, and things that I think are more relevant to all of you. Just from a disclosure perspective, I have received some speaker honoraria from Sanofi Genzyme. Amicus Therapeutics did some consulting for them some time ago. And I am the founder and CEO of a company called Exerkine Corporation. And we've filed for a patent in Canada and the US for a ketone compound that we've developed to enhance the benefits of enzyme replacement therapy across all lysosomal storage diseases. So there's conflict there, just so everyone knows up front. So I'll go through some of the objectives. They're similar to what we did when we did the scientific talk, but of course, I'll emphasize the important things that I think are more important to patients and other caregivers and stakeholders. So we'll go through the pathobiology just so everyone's aware of what causes Pompe disease. I won't spend too much time talking about diagnostic testing for other disorders, which I did for the clinical talk for doctors, but I'll focus more on exactly what does Pompe disease do, what muscles are most affected. And then importantly, I'll spend most of my time talking about what evidence is there for therapy. We'll go through exercise, nutrition, enzyme replacement therapy. And then, of course, people are probably familiar with the fact that there are two new enzyme replacement therapies that were presented at the World Meeting in January of this year, both what's called NEO-GA and AT-GA. NEO is from the Sanofi company, AT-GAA is from Amicus. And then I'll just show you some of the stuff that we and others are doing in animals to come up with new strategies for Pompe disease if we have time at the end. So Pompe disease is named after the Dutch pathologist J.C. Pompe, who's a Dutch pathologist who first described the neuropathological features of a child with classic infantile onset. So the child on your left here with the profound hypotonia, these kids usually have significant cardiomyopathy and respiratory issues. That was the classic disorder, but most patients actually have the late onset form, which it's a strange disease. When you say late onset, essentially anything after 1 year of age is considered late onset, and we'll show you that in a minute. So the disease is characterized by deficiency of an enzyme called acid alpha glucosidase, and we'll show you how that works in just a minute. And I'll show you what the issues are when this doesn't work properly. So as mentioned, this is a genetic disorder. So it's a recessive disease. So you need a bad gene from your mom and a bad gene from your dad. With both of those genes, if they're defective, if they lower enzyme activity, usually below about 30% of normal, you get a deficiency. And so you can't keep up with the glycogen that builds up in our cells. So glycogen is present as an energy source in skeletal muscle and heart and several other tissues, but those are the ones that have most glycogen. And what happens is normally we have essentially a garbage removal system, and that's called the lysosome. So what happens is in our cells, when we build up damaged proteins and other molecules, the lysosomes come in and they eat up the bad stuff, sort of pruning a tree, for lack of a better term, in the springtime, so the good stuff can work better, get rid of the garbage and kick it back out again. As we do that, stuff gets stuck inside the lysosomes. And one of the things is glycogen. So it's almost like a Pac-Man eating up these bad proteins, but glycogen sort of comes along for the ride because it's so abundant. Normally, we remove that glycogen and break it back down to glucose through the GAA enzyme. So in the glycogen here with these little yellowish brown discs, when it builds up, normally we just remove it as glucose. But if you don't have GAA, it builds up. And then glycogen eventually, as you can see here in this picture, this sort of purple stuff is glycogen. It all should be blue. These are muscle cells. And all of this purple stuff is sugar accumulation. And it's massive, and it's pushing the muscle cells out of the way, as depicted in this cartoon. Obviously, if you fill your muscle up with sugar and you displace your contractile proteins, you're going to get weakness. If it happens in the heart and lungs and it's severe, you get this infantile onset. If it happens in the muscles slowly over time, you get a neuromuscular disease with exercise impairment first, eventually difficulty getting out of a chair, difficulty getting up and down stairs, and eventually requiring a cane, a walker, a wheelchair. In addition, the diaphragm is affected in the late onset form as well, and people usually need BiPAP at night as it gets worse. But some folks go on to full-time mechanical ventilation. Now, we do see this a little bit more in the infantile children who are treated, who survive their cardiomyopathy, but they end up still with significant muscle weakness. So it's a broad spectrum disease. I'm in both a pediatric and adult service. So I see the few children, because it's a little more rare to have this fatal infantile form, with a rapidly progressive floppy baby syndrome with an enlarged heart and respiratory insufficiency. As mentioned, the crazy thing is you either have this severe infantile form where cardiomyopathy, profound hypotonia, and respiratory insufficiency occurs, or if the person is more than 1 year of age, it's considered late onset Pompe disease. And we certainly have some patients now who are, one guy's in his early 40s, he was diagnosed at age 2 at sick kids with weakness and ended up in a wheelchair by the time he was in his late teenage years, still alive, but that person diagnosed at age 2 is late onset Pompe disease. But we also have mild patients diagnosed around the age of 50. And this is largely due to the residual enzyme activity. So if you're close to 0, this happens to you. If your enzyme activity is 2 or 3, you have the earlier onset. If you have an enzyme activity closer to 30, you have much later onset. So there's quite a spectrum. But the spectrum here, there's a spectrum, but there's the average. So most people, the first complaints usually come in your late teenage years, in your mid-20s, and most people have exercise intolerance. So they're okay just getting out of a chair and doing their regular activities, but going up 3 or 4 flights of stairs. They, for example, go to Europe, tour around and walk much more than normal. And I've had patients say that they were going up, it was in Greece, going up some stairs to some ruins, and that's where they noticed their weakness. But certainly at home, people notice if you're carrying a grocery containers or laundry basket and you can't use your hands and you go upstairs, that's where people first start to notice it. So usually some form of exercise intolerance. Usually it's a slow progression. So there can be up to a 10-year lag between your first symptoms and finally getting a diagnosis. Now that may be due to patient factors. They just think they're getting older. In your mid-20s and 30s, you got young kids and you're starting a career. You think, oh, I'm just not doing too much exercise and I'm just getting lazy and out of shape. But eventually, people get to their family doctor, eventually referred on to a neurologist and to a neuromuscular clinic, and finally get their diagnosis. But it can be quite a period of time from your first symptoms to getting the diagnosis. By the time people are diagnosed, they usually have significant proximal weakness. So problems getting out of a chair, out of a bathtub, going up and down stairs, getting out of bed is sometimes even a challenge. And most people will start to have some respiratory issues first noted at night with what's called nocturnal hypoventilation, where you're not breathing enough when you lie down, because when you lie down, you need your diaphragm more, and that's more affected in this disease. And that's why people sometimes need BiPAP support at night. Now, as time goes on, of course, disability progresses to the point where people can't go upstairs. They need a stair lift or live on a one-floor area. They need a cane, they need trekking poles, then they need a walker, then they need a scooter or a wheelchair. And eventually, if the breathing gets worse, you don't just need breathing support at night, but some people need even a tracheostomy and breathing support during the day. Again, the minority go on to a tracheostomy. Most generally get by just with the breathing support at night. But the goal, of course, is to make this diagnostic odyssey from first symptoms to getting a diagnosis a little bit shorter so that people can start on the appropriate treatment, which we're going to talk about. So as mentioned, there's often a delay in diagnosis for reasons that we talked about. For the vast majority of people, it's leg weakness first. So people notice it going upstairs, getting out of a chair first. And even some of our patients that have quite severe leg weakness still have pretty good arm strength, even decades after the disease. The only exception is the scapula, which is your wing bone back here when you're reaching for things. Sometimes that can be weak early on too. I mentioned before also that it's usually exercise intolerance, difficulty running, climbing stairs, or biking. Mid-onset is in your 20s, but it can be anywhere from 1 year to 70. And in the mid-40s, most people are using some significant gait-assistive device like a scooter or wheelchair, and you usually need some sort of nocturnal support. Unlike the pediatric form, where the heart is your biggest issue by far, and that's what kills the kids usually before 1 year of age, for the adults, the cardiomyopathy or enlargement of the heart is no different than the general population. They can also get an impairment of the electrical activity called Wolff-Parkinson-White syndrome, where the electrical activity comes in a little soon. That's usually asymptomatic, but may need a pacemaker at some point. So again, how do we make the diagnosis when someone comes in who's got weakness, they've got shortness of breath? We do a full neurological examination, and when we find that they've got weakness of the hip flexors, the muscles that bring your legs together called the adductors, and that's why sometimes the legs tend to splay out when people are walking. When we see that, we say, aha, this is a muscle disease. We usually send blood work. CK, which is your creatine kinase, is a blood test, which is reflective of damage to the muscle. We often will do an EMG, which helps us to separate out different types of muscle disorders. And we see classic features, which I'll show you some examples of in a minute. And then we often do a muscle biopsy, because people don't come to us saying, I've got Pompe disease, diagnose me. They come to us saying, I'm weak, and it could be any one of 130 different muscle disorders. One of the things that helped us to speed up and identify a few rare patients is called a dry blood spot, and I'll show you what that looks like in a minute. Again, I won't say too much here other than just to highlight that this is a progressive disease, and people's muscle strength goes down about 1.3% per year. Everyone's different. Some people are stable for a long period of time. Other people go down at 7% per year. But over time, as the glycogen accumulates, people will get weaker. And we can see it, especially this is a muscle here I've highlighted called hip adductors. So when you walk, if your adductors, which bring your legs together, are weak, your legs tend to splay out, and people have a very characteristic waddling gait. The lower back is also affected, and that gives people the sway back. Some people call it, the technical term is lordosis, and we see that in most of our patients. There's also scapular winging. So if you put your arm like this and you push up, the scapula can ride up like that, and it makes it hard to use your arms above your head. There's a rare thing, but I've seen it in one of our patients. They say that 15% of people have ptosis, which is a droopy eyelid. If that happens, usually it won't respond to any therapy, but there are some surgical interventions which can lift the eyelid up, and they work extremely well. Breathing, just like the legs, gets worse over time. It's very insidious and slow. Some of the things to think about, if you have respiratory issues at night and you're not breathing enough, you don't blow off carbon dioxide. So people often wake up absolutely trashed in the morning. Their CO2 levels are high, and that's when somebody needs this BiPAP. And it's important when we test patients, we do a thing called spirometry, where you've probably done it, and you blow into a machine. When you go from sitting to lying down, if it drops more than 20%, that means the diaphragm is involved. And what we do in our clinic is we start checking patients sitting in supine. If we see that the sitting levels drop below 85%, we start doing more careful intervention. When it drops below 75, we refer to a respirologist, and we do various studies like and interventions, I should say, like breath stacking, where people will do breathing exercises to improve their lungs. And we do nocturnal studies. So we do studies at night to check to make sure that the oxygen levels are okay and you're not building up this carbon dioxide. Generally, men tend to progress a little more rapidly than women. So this is what the muscle biopsy looks like. So when we do our needle biopsy, we see these little blebs, which is just the sugar accumulation. This is a special stain that shows the increase in lysosomes. This is a sugar stain showing big globs of sugar inside the muscle. And this is the difference. So IOPD is the infantile onset. And you can see all of this is sugar accumulation with very few muscle fibers left. And that's why these kids are profoundly weak. And even with enzyme replacement therapy, the muscle's so damaged, they're still very, very hypotonic and weak. In adults, this is a milder case with some sugar accumulation under the muscle membrane, but the muscle fibers here at the bottom still look pretty good. This is what an EMG looks like. It should be completely silent at rest, but we can either see these little picky things called fibrillations and positive sharp waves, or these loud sounding things called myotonic potentials. And then when the muscles contract, normally they should be tall like this, but you can see if there's damage, they're much smaller and shorter. This is something that sped up the diagnosis for some people. So if you go to a neurologist or a neuromuscular center, in addition to sending a genetic test, and usually it's more of a what we call a panel, where we're looking for a variety of different disorders. We also drop some blood on this little card, and we specifically measure the enzyme activity. If it's low, then we do a detailed assessment for Pompe disease. So we put little drops of blood on the paper, and we send it in, and we measure the enzyme activity. If it's normal, you've ruled out Pompe disease. If it's low, you still may be a carrier, but we have to do the testing to find out. So the testing that we do is genetic testing. I won't spend too much time on this, other than there's over 400 mutations that have been described, and they've been nicely curated at this center. In North America and in Europe, there's a specific mutation that's quite common, but there are ethno-specific mutations that have been seen as well. So let's get to, you're diagnosed with this, and indeed with pretty much any myopathy. What are things you can do? So these are your general things that people should be thinking about from a therapeutic perspective. First, I think it's really important, especially in Canadians, to check for vitamin D deficiency. We've been checking for the last 20 years, and we find that 85% of our patients are not meeting current Canadian guidelines, and 13% are in the rickets range. So most of you are probably not old enough to remember rickets, which is a disease of bone formation in kids who are severely vitamin D deficient. What people seem to forget is there's a thing called rickets myopathy, where children who have rickets also get severe muscle weakness. And we've had medical residents come to me thinking that they had a mitochondrial disease. And I saw them and said, look, you don't. Let's do some blood work. And both of them had non-detectable vitamin D. Their muscle enzyme was up. They were weak. They were fatigued. We replaced it, and it went right back to normal. So if the levels are less than 25, that's critical. And that alone can cause muscle weakness. So if you've already got a genetic muscle disease, you're pouring gasoline on a fire. So in general, we find that 85% of our patients are into normal range with 2,000 units of vitamin D. But no one is going to be severely deficient on 2,000 units a day. However, when we do find this, we put people on 5,000 units a day for a few months and then drop them back to 2,000. Also, indeed, for most muscle disorders, if you shrink your muscle, you can't get rid of sugar very well, and you're at greater risk for type 2 diabetes. So we recommend that that gets checked once a year. Hypothyroidism, again, not that our patients are at increased risk, but this is such a common disorder that it's good to get it checked once a year, especially if you are feeling okay, and then all of a sudden you start feeling more tired, putting on weight, and feel lethargic and cold all the time. very easy to identify and treat. We'll talk about exercise a little bit more in a minute, but in general, for all myopathies, it's important to exercise. Now, you don't want to overdo it, and everyone's a little bit different depending on what your background is and how severe your disease is, but you shouldn't be doing something that's so intense that you can't do 12 to 15 repetitions. So every time you lift a weight, that's 1, 2, 3, 4. If something is so heavy you can't lift it more than say 10 to 12 times, then you've got to cut back on the weight until you could at least do 3 sets of 10 to 12, or sorry, 12 to 15 repetitions. Now, as time goes on and people get weak, you don't want to fall, especially on uneven ground and with hills. So a lot of our patients, what we're recommending now are trekking poles. And these are essentially ski poles with handles, and you use one in each hand. They're super lightweight. You can get them at sale. You can get them at Mountain Equipment Co-op. And I think they even had them at Costco for a period of time. But good quality trekking poles are actually better than a cane for getting around because you have a little carbide tip on the bottom, so they'll stick into the concrete or ice. And you can put a little rubber tip on the end when you're inside a house or a store or whatever. Eventually, patients usually need a walker when things get more severe. You can lock it out and use it as a seat as well. You can put your groceries in it. And many people probably would benefit from a walker when they realize when they go to Costco and they're pushing the shopping cart and they say, oh my goodness, that's so much easier for me. I feel so much more stable. So if that's the case, consider a rollator walker. But sometimes as the weakness gets worse, people are falling and they just are at too high a risk. And we go on to either a scooter or an electric wheelchair. Again, sleep study is important for people who have some respiratory issues. From a diet perspective, we recommend a little bit more protein than the average person. So we recommend 1.2 grams of protein per kilogram per day. Generally, meat, fish, eggs, and milk-based proteins are the highest biological value. So all these plant-based proteins and stuff are very low biological value, and it'll be very hard to get proper protein and enough protein. And finally, essentially every muscle disease benefits from creatine monohydrate. 100 mg per kilogram, that's what we use for kids. For adults, bottom line is you just take a heaping teaspoon, which is about 4 to 5 grams, which is about 3 times your normal dietary intake. And the reason we suggest that is that it is leaking out of muscle. That's what the CK is. It helps in this reaction. And so people are creatine deficient. We have worked on a Cochrane review where we looked at all different types of muscular dystrophies, and it concluded an increase in both strength and muscle mass with creatine. Extremely inexpensive. Cost you about $30 at a President's Choice store, and just mix it into yogurt or applesauce or whatever, and take it just once a day with your breakfast, and that'll give you adequate amounts of creatine. Inexpensive, very safe. The only side effect is tummy upset in about 5% of people, which is lessened if you take it in the middle of a meal. So those are generalized things that pretty much everyone with muscular dystrophy should do. But I'll show you, and this is something we did with muscular dystrophy patients, but it is exactly the same for Pompe patients. So we did a study with 51 patients with myotonic dystrophy, limb girdle, and FSH. We did prospective dietary analysis. So everything that they ate, they wrote down, and they were counseled by nutritionists how to do this properly. We did 3 days of collection and separated that by 5 months, did it again, and took the average, and we compared it to the dietary reference intake for Canada. What we found is most patients are not getting enough calories. And the reason for that is if you're not moving very much because you've got muscle weakness, you don't have the need for so many calories. Otherwise, if you put in too many calories, you're going to get overweight and obese. And so as a consequence, many vitamins and minerals were deficient, probably just because people can't get enough food in. So one of the things that is recommended, or we recommend based on this study, is everyone with muscular dystrophy should take a balanced multivitamin. So again, whatever brand you want, Kirkland brand, Shoppers Drug Mart brand, some balanced multivitamin makes a lot of sense. Protein intake was reasonably low in some folks. Now this is compared to the average person. which should be 0.86. But for our patients with MD, where it should be 1.2, these numbers are much higher. So very few people are actually getting the optimal protein for a patient with muscular dystrophy. And that's why sometimes supplementing with, if you're not taking milk, eggs, meat, and fish, you may want to supplement with a whey-based protein, not a plant-based protein. So in terms of exercise, well, in general, we think there's lots of benefits from exercise over and above just improving your muscle. We know that a lot of our patients, when they don't move, it's hard to burn calories, and a lot of patients do become obese. Even if they don't look obese, when we put them on the DEXA scanner, even patients who look thin and cachectic, they actually have an increased body fat, and that increases the risk for heart disease, diabetes, etc. So doing endurance exercise is good from a cardiovascular health perspective, and it helps to decrease the risk of obesity. There's a process called autophagy, which is cleaning up damage inside muscle, and I'll talk a little bit about that with our research. I won't get into that. And with resistance exercise, so weight training, and you can do this with weight machines, TheraBands. There's a whole bunch of ways to do it. We just published a study in 2019 with very frail older adults where we did resistance exercise bands. You probably heard them called TheraBands, and we actually found quite significant improvements in strength, especially when combined with good quality protein and a bit of creatine. The other benefit from doing more resistance type activity is it improves your bone mineral density, and with more muscle mass, it helps to decrease the risk of diabetes. So again, just to show you that we do lots of research in this area, I won't get into the nitty gritty, but we have mice that have Pompe disease, and we've done exercise training to really understand, how does exercise work at the molecular level, and does it work? And what we found is definitely the animals with Pompe disease that we exercised did better. And when we treated them with the enzyme replacement therapy, which is the standard of care, what we found is that there was an added benefit from exercise. So what we found is that the animals who exercised could run longer. And remember that exercise intolerance is the first symptom of Pompe disease. If your muscles are being damaged, you produce these things called free radicals. Most of you have heard of antioxidants, which are in a variety of foods, and you can get some antioxidant supplements. So that oxidative stress is higher. And naturally, when you exercise, you make your own endogenous antioxidants, and it lowers oxidative stress. We also increased a powerhouse of our cell called the mitochondria, which can be impaired in Pompe disease. And we activated something called autophagy. So there's an excellent researcher called Nina Raben, R-A-B-E-N, who actually created this mouse model of Pompe disease. And she's been a real world leader for about 30 years in the area. And what she thinks, which I agree with, is that with Pompe disease, it's not only the buildup of glycogen, but when that happens, you impair something called autophagy, which is the ability to go around and clean up the cell of bad proteins. And so activating that process again helps you to clean up the bad proteins that accumulate as we age. And that's important in terms of improving function in Pompe disease. So is there any evidence that exercise helps patients with Pompe disease? This was a study by a German group where they looked at 44 patients, and they measured their response before and after a year on enzyme replacement therapy. So this is the 6-meter walk test. So you just essentially, 6-minute walk test. So you walk for 6 minutes and you see how far you can go. And you can see some people did worse, some people did better, but what their point was is the people in the dashed line here all exercised while they were getting an infusion. So what their thought was is maybe with the exercise, the body was taking up more of the enzyme replacement therapy. That was just a speculation. Our animal studies showed that that's not the case. It's just the exercise itself activates autophagy, increases your mitochondria, and that's how it's working. But at the end of the day, who cares how it's working? If you're a patient, you just want to walk better. You want to walk longer before you need a walker or a wheelchair. So improved function is improved function. And clearly those who do activity do better than those that don't, on average. So another study did what we've shown helps in older adults. And that is, it's not just strength training or resistance training. And it's not just endurance training that work, it's better to do both. So this was a study by a group in Greece where they took 5 patients who were stable on enzyme replacement therapy. And they did 5 months of supervised endurance and resistance exercise 3 times per week. And what they found, depending on the muscle they looked at, was a 15 to 50% increase in strength. And their 6-minute walk test went up by 45 meters. So I know the drug companies don't like me saying this because their $1 million a year therapy increased their walk test by 31 meters. And on top of that, they got another 45 meter increase in the 6-minute walk test just by exercise. So they were all stable on ERT. And you can see they got this extra bump in their 6-minute walk test. And you can see that these folks were pretty weak, right? Because 6-minute walk test, the normal should be around 600 for the average person. So these folks are pretty impaired, and they still were showing the benefit. This just shows the same thing, just to show that it's not just one study, that the group in the Netherlands looked at adult patients, again, who had been stable on ERT. They exercised them 3 times a week for 3 months. And what they found is that most people could tolerate the program. The vast majority could, and they increased their cycle capacity, their maximal oxygen consumption, 6-minute walk test, and their quantitative strength test. So again, pretty much everything went up. So confirming what we've shown in animals, confirming what patients tell us, confirming what the Greek group showed. And this is the biggest group in the world showing the same thing. Now, people talked about exercise and nutrition for years. This fellow in New York called Alfred Slonim came up with this NET therapy, and that's nutrition and exercise therapy. Bottom line is, with nutrition, he increases protein. Fairly normally we eat about 10% of our diet is protein. He's suggesting 25 to 30%. This is probably, I think, a bit high. I actually did my PhD in protein biochemistry, and I would say probably around 15 to 20% is more than adequate. But nevertheless, keep a higher protein intake, which we've always said, try and get it over 1.2 grams of protein per kilogram per day. And again, a moderate fat intake here. And this is where I would change things around. I think slightly lower protein, carbohydrates can be a little bit higher, and fat shouldn't really be much more than 30% from a health perspective. And then what he does is exercise on a treadmill. Now, practically, I don't give a rat's, but if it's a treadmill, if it's an elliptical, if it's a reclining bike, if it's a QB on the floor, just get out and do it. All of them are pretty much equivalent in terms of the benefit. And with the treadmill, it's sometimes hard to get on and off. They're a bit noisy. So certainly if you like an elliptical or stationary bike that's got a nice quiet magnetic spinner, you can watch Netflix, read the paper, whatever. It's going to improve your compliance. So what he showed is that if you look at the patients before they started NET, this is their strength scores were going down, and it tended to stabilize after they started this. Again, not very quantitative, but I think it does show that people who are rapidly getting worse tended to stabilize when they started with exercise and nutrition. So bottom line, I think when you're exercising, a mixture of both is good. We always say start off slow, take your time, listen to your body. So if you're really achy the next day, take an extra day off, and always have a harder day and an easier day so that your body has time to adapt. Be careful of energy balance. Again, since when people don't move very much, they don't eat very much. And sometimes then you're not getting the full repertoire of calories, and nutrients like vitamins and minerals, and enough protein. So try and remember that 1.2 grams per kilogram and see if you can get enough. And again, we always suggest check and replace deficiencies. Certainly iron stores in women, which we use the thing called ferritin. If it's low, that's the most common cause of generalized fatigue in middle-aged women. And getting that number over 50 really had a major effect at lowering generalized fatigue in middle-aged women in a study published about 7 years ago in the Canadian Medical Association Journal. Vitamin B12, quite common as we get older. And if it's deficient, it can cause dementia, it can cause neuropathy. Vitamin D can cause myopathy on its own. So it's low-hanging fruit just to check and replace, bring people back to the norm. And that's the same for every neuromuscular and metabolic disease. protein intake, 1.2, I don't think higher than 1.6 really helps, but somewhere in this range is good. And then people have asked me the question, and I was at a big Pompe meeting last year where people were talking about this ketogenic diet, and I'll talk about that right at the end. So I'll just show you briefly what the standard of care is. There's something called Myozyme, which is the brand name for the Genzyme product, and I'll show you what it is. Some of you may be on it and may not fully know what it is. So Myozyme essentially is recombinant GAA. So as you know, if you have the messed up gene, you don't make GAA protein, you don't break down the glycogen. So recombinant just means that it's made in a big bioreactor. So essentially it's this big vat of what we call culture media, which has sugars and amino acids in it. And it's just at the right temperature for these Chinese hamster ovary cells, which are genetically engineered to spit out this recombinant protein. So then they siphon off the protein, purify it, sterilize it, and it's injected back into the vein. So in blue here, this is just a depiction of the recombinant enzyme. It binds to this thing on the surface called a mannose-6-phosphate receptor. It gets internalized into these things called endosomes. The endosomes eventually fuse with the lysosome. And so what the theory is by providing this exogenously, it's going to go into these lysosomes that are deficient in the enzyme. But by delivering stuff from the outside, we call that exogenous enzyme replacement therapy. The lysosomes will then have it, and you'll start to break down the sugar and slow down the disease process. So the approval for this in Canada, US, and many other countries was what's called the LOTS trial, late onset Pompe disease trial. And this was my colleague, Dr. Ens van der Ploeg from the Netherlands, published in the New England Journal of Medicine in 2010. So they had 90 LOTS patients. They looked at the 6-minute walk test and forced vital capacity. And again, this is the dose most people are on, 20 mg per kilogram every 2 weeks. And they studied them for a year and a half. So what they found is that placebo, just like we had mentioned earlier, the breathing capacity here is reflected in what's called the forced vital capacity, which is how much you can blow out, goes down around 2% or so per year. And yet when they were on the Myozyme product, it's stabilized. Then in terms of 6-minute walk test, again, not much of a change over the year. Normally it goes down about 1.2, 1.5% per year. But in this study, patients are engaged, so they're probably doing a little bit more activity. But still, the point here is there was a big difference between those on placebo and those who were getting the Myozyme. Well, not a big difference, as I mentioned. The exercise alone showed even more of a difference there in that Greek study, but enough that it was stat significant, and the regulatory bodies felt that this was an improvement and approved this in North America. So people may have heard that there could be some new therapies that are coming. I'll just show you 2 that are most likely to be around, I would expect by next year. So one of them is called the PROPEL study. Again, some of you on this call might have been involved in this study. It was sponsored by Amicus Therapeutics. It was a phase 3 study. And what we mean by that is the patients are on either placebo or the enzyme, and neither us, the patient, nor the people who sponsored the study know who's on what until everything's done. Then we do what's called a data lock, so that nobody can then change the data, and then they tell people what they were on, and then the statistics people can analyze it and see if it worked, so that there's no bias, so people don't cook the books. So the background here is with the GAA enzyme, it normally sits in a lysosome at a pH of what we call an acidic pH. So it's almost like lemon juice. It's around 4.2, 4.3. And so our blood is around 7.4 pH. It's more basic. And so when the enzyme comes in, it tends to denature because it's not in the right pH. So these chaperones help to prevent it from denaturing. And also when they go into the cell, the chaperones alone can sometimes stabilize. If there's a little bit of mutant enzyme left, it can make that enzyme work a little bit better. So the theory is if you combine the chaperone with an enzyme replacement therapy, there's more of the enzyme replacement therapy that's going to get in, and you may activate some of your endogenous enzyme. So there was lots of animal studies, and we were involved doing biopsies on patients years ago to show that this actually, in theory, should work, but it needed to be studied. So what they did is a phase 3 study. Patients were all over 18 years of age, and they had both ERT naive and experienced. So experienced means that people were already on the Myozyme product, and then they came into this study and they either went on the new Amicus product or they stayed on Myozyme. And other patients came in newly diagnosed and they either went on the Myozyme product or they went on this regimen. So you can see here that there were more people in the new product than were on the Myozyme. Experienced, that means that those who are already stable on Myozyme switched to this product. 20 were newly diagnosed and went on this product. 30 started on Myozyme and stayed on Myozyme. 8 of them had not seen anything before, were newly diagnosed and put on just Myozyme. It was a year long, and then there's an ongoing extension, which we're still part of. So the primary endpoint was 6-minute walk test, and then the vital capacity was a secondary outcome. So this is all comers. So that's both the new patients and those who switched. So if you look at the 6-minute walk test, there is an improvement with the new product, an improvement with the Myozyme over what you'd expect for natural history. It looked like it was going to be different here, but generally we like this to be 0.05 or less. So it didn't quite meet the quote primary endpoint. I hope none of you were invested in the company because the stocks dropped like 25 to 30% the day after this happened because they didn't meet their primary endpoint. In contrast, their secondary endpoint here, called the forced vital capacity, they found that the decline was less for the new product versus the Myozyme product, and that was less than 0.05, so that was significant. Now, you have to take a look at this a little more closely. So these are the experienced patients. So these are people coming in already on Myozyme, which represents, most of the people in the population at this point in time. And so what they found, again, this is a 6-minute walk test, that with the Myozyme, they just kind of stayed the same over that time period. And the folks who switched to the new one got another bump. So these patients who switched, if we will, to the new product got a further bump over and above what they had already been experiencing with the Myozyme. And that was statistically significant. From a breathing, again, showed the same thing, that they continued to go downhill if they stayed on the Myozyme, but if they switched to the new product, there was an improvement. In contrast, what's interesting is coming into the disease. So you're newly diagnosed and you're going to go on therapy. There was no difference between those that were randomly allocated to get the Amicus product or the Genzyme product. And what's interesting is that this improvement here is very similar, actually even a bit better than the original LOTS trial. But again, there was no difference between the groups, but both of them showed benefit. And then what's strange, I think, again, probably because of small sample size, is that there was a continued decline in forced vital capacity for both groups who were newly diagnosed and put on the therapy, which is a little bit strange because normally you only go down about 1.5% per year. And here people were going down almost 4% in spite of being treated. And recall with the original Myozyme study, there was no drop. It was stable over that time period. So I'm not sure what to make of it. Maybe there were a few outliers, but I think what it shows is certainly from a walking perspective, there's not much benefit from one versus the other if you're newly diagnosed, but switching, it looks like there's probably some benefit. So the other study, competing study, obviously the companies are freaking out because one of them wants to be the only therapy so they can get their $1 million a year for their therapy. So Sanofi was racing with Amicus to try and come out with a product, and they both published their data in the same conference within days of each other. So this is a slightly different strategy. Sanofi decided to take their Myozyme and add some extra sugars on it so that it would bind to that receptor, that mannose-6-phosphate receptor. So I'll use the term AVA now for the new Myozyme, because AVA is just the carbohydrate, modified enzyme replacement therapy. And certainly the animal studies show that this should be dramatically beneficial. So essentially they did a study which was 1 year in length, and they just randomized newly diagnosed patients to either AVA or to the Myozyme. So phase 3 study again, and they were randomized either to the standard of care, which is Myozyme, or this new drug. And what their hope was is that the new drug would better improve the forced vital capacity. And then they had a bunch of secondary outcomes. So it was kind of switch. Amicus chose the 6-minute walk test primary, forced vital capacity secondary. This company chose forced vital capacity primary, 6-minute walk secondary. So again, this is what was seen in the original LOTS trial. So this is the original with Myozyme versus placebo, just to remind you what it looked like. And here what we have is, again, very similar results to those who were put on Myozyme, and that was a stability over a year. This is pretty much exactly the same, if you recall here, as that green bar on top, right? So stability there. So they kind of replicated their own data, but what they showed also is that the AVA appeared to be better. Now, they had this crazy statistic stuff, superiority versus inferiority. Superiority didn't quite meet the primary endpoint. So that means it wasn't quite 0.05, pretty darn close, to say that this is better than this. But this means that it's definitely not worse than this. But I think anyone logically looks at it and says, probably going to be a bit better. And then they also looked at the 6-minute walk test. And here they did show that this improvement was better than this improvement. This is a little bit weird too. Again, you know, from study to study, there's a bunch of things that are a bit different. In this case, it was a little strange because in the first lot study, the improvement in 6-minute walk was around 30 meters. And here it was only 2.9. But still, it looks like this is a slightly better product than this. Again, didn't hit it out of the park, but you know, overall, if cost is the same, side effects are the same, probably makes sense to that there's probably some benefit from this. And again, I just showed you here that with the first Myozyme, it was plus 25 meters. And you'll look here again, you know, it's pretty similar to what they showed here, but it was a little surprising that the Myozyme would look like it was moving that direction, but then this last outcome looked like it was a little bit lower. So what we'll do in the interest of time, I wanted to leave 10 minutes. That was the final component there. The rest is kind of more scientific-y stuff, but I'll just finish with the folks that have contributed, especially Mats Nilsson did a lot of our animal work, a lot of the other folks in the clinic, especially all my clinic support here, Lauren Brady, my genetic counselor, and a variety of national and international collaborators, and the folks that supported our work. So we'll open it up to questions for 10 minutes, and we'll go from there.
Thank you so much. That's an excellent talk, as always, so informative and insightful. We do have a few questions that have appeared in the chat. I welcome others to go ahead and put in their questions in the chat box as well. One of the questions is around what you just mentioned a few moments ago, around the different ways that industry tracks outcomes, whether it be a 6-minute walk test and there's a change. Do you know what is the gold standard in terms of measuring outcomes with the different therapies or drugs? Or what would be?
Yeah, the companies don't track you once, you know, we as clinicians give you a drug. It's up to us to decide what drug we're going to give in consultation with you, and we explain the risks and benefits. And then it's up to us to decide with you if you think it's working or not working. The problem is that if you're put on something and there's lots of hope that this is going to work, there's a huge placebo effect. So we need to use some more objective outcome measure. And therefore, in the clinic, in our clinic, we have a very fancy $150,000 machine, which measures exactly how strong your leg is, your arms, and that's very reproducible. And we use that as part of our decision-making process. We also have some functional tests, so people can do a 4-stair climb. We have a get up and go time, you know, and then we add that plus, you know, our MRC scale is pretty insensitive. And then, of course, the 6-minute walk test we use for research, and the companies and the regulatory bodies love the 6-minute walk test. And at first, I wasn't as much of a fan of that, but I'm becoming more and more enamored with it because it does correlate very nicely with our knee kicking machine, and it correlates well with function. So that's how far can you go in 6 minutes. It's important to do it in the exact same, you know, 50 meters down, 50 meters back. Somebody who knows how to run the test, to do it in a hallway where no one's going to cut in front of you, like if a nursing class comes out and 50 kids cut in front of you. that's going to screw up the test. So that's the only challenge with it, is it's hard for clinics to have a place to do that, except during research, we close off an area and do it. So I think ultimately, and I tried to discuss this with my colleagues, we need to come up with things that we can all use together so we can talk the same language and we can follow patients. Because I think it's completely inappropriate for a patient to be on a medication and not get benefit from it, but for them to still expose themselves to a risk, however small it might be. Life is risk and benefit. And if at the end of a year or 2 years, the patient doesn't feel any better, and we can show them the data to show that it's really not having an impact, then they can make an informed decision with us to say, look, let's not continue with this therapy. It's just not working. And again, we do that all the time with exercise, and we show the benefits there. We are, when we renew our Myozyme, putting in our strength test, our breathing tests and such, but definitely also with Pompe, you should be doing your spirometry sitting and lying down, and those numbers should go in as well, because that's been so well documented. And the important thing too, I should point out, is whatever test you're using, make sure you know what those numbers are before you get treated and after you get treated. Because we've had patients who are stable over a year with their spirometry and their strength test. We've had people going down at 7% per year. So if you don't know what that person's trajectory is, you don't know if your intervention is helping or not. So one of our ladies with Pompe disease was dropping at 7% per year in her breathing. We put her on enzyme replacement therapy, and it plateaued to 0% for the last 4 to 5 years. But again, if you didn't know that she was going down at 7%, you'd say, oh, well, it's kind of not doing anything because she's not changing. But she dramatically was changing. You got to know where they were coming from. So again, what I want to do across Canada is to say, let's do the forced air climb, because everyone can do that. And we're going to do the get up and go time, which we use in our kids more often now. And we use it for older adults because that's very reproducible. And I think every clinic across Canada can use that. And I think that's going to help to say, should you stay on the drug or not as we move forward.
That's great. Thank you so much. There was a comment as you were talking that came in that many of the measures that you're using and tracking in terms of enzyme replacement therapy are not being used throughout Canada. They're sort of it's not consistent across what their clinicians are providing in terms of post-follow of enzyme replacement therapy. But I think that this is great that you're highlighting some of the work that you're doing. Another question was, and maybe you can do this offline, was the citation for the comment that AVA looked very beneficial in the mouse model.
Oh yeah,
study. I can get that from you for sure.
Yeah, I'll send you that paper. Yeah. But again, at the end of the day, most models are great to do your preliminary, proof of concept, show how it's working. And if it ain't better in a mouse, you're not going to go on to do human studies, right? So you always start there, but what works in a mouse doesn't always work in humans. So what we really care about is that phase 3 clinical trial, because I've been involved in so many studies where things look great from mice, phase 1, phase 2, and then they fail miserably in a phase 3 study. So, you really need in a phase 3, because the placebo effect is shockingly powerful. And if you know what you're on, you're going to get benefits. Like, for example, in spinal muscular atrophy, when people are on the therapy, they want to stay on the therapy. So the parents train the little kids, 7 days a week to do better on their tests. So how can you say it's the drug when the kids are training specifically to do better in the test that we're using to determine if they're going to stay on it? It's exercise training, it's probably 90% of the benefit you're seeing. So that's why those phase 3s are really the critical thing. Now, they haven't been published yet. They were presented in its publicly accessible presentation as an abstract, but the full paper is not yet out on the COMET trial or the Amicus trial.
Another question similar to the comment that I just made that's coming in is around, you mentioned in your talk today, standards of care for Pompe. What would you think is the biggest gap or not really addressed in terms of standards of care in Canada?
Yeah, I think the biggest gap is, and again, perhaps it's because I did my PhD in a nutrition department. I did my cell biology and metabolism degree in a group, so I was exposed to people that know a lot about nutrition. People think it's not real neurology, it's not real science, it's not real clinical care to think about optimal protein intake, vitamin D status, vitamin B12 status, and all of those attentions to detail, it's critical. Diabetes, people say, oh, well, they're not really that diabetic. Let's just sit and watch. But abnormal sugars screw up your mitochondria. Mitochondria are already screwed up in Pompe disease. So my point is, it's attention to every little detail, and it's the little things that make a difference. And people have made fun of me for the last 26 years because we pay attention to detail and saying, oh, it's not genetic therapy, it's not real neurology. But give me a break. Other than spinal muscular atrophy, doing gene therapy in the kids identified newborn screening. There's no gene therapy for any disease. We're not curing any disorder at all. But people get dramatic benefit by looking after every little detail of the small stuff. And I think it's the nutrition, it's the exercise, it's the identification of deficiencies, which a lot of people aren't thinking about. Now, finally, some of my colleagues are checking vitamin D, they're replacing it, they're thinking about it after I've been flogging a dead horse for 26 years to educate people in these things. And you can see, look at that study from the folks from Greece. Simple supervised exercise 3 times a week increased 6-minute walk test by a greater magnitude than you saw with AVA, by a greater magnitude than you saw with the Comet product, by a greater magnitude than you saw in the LOTS trial. So, tell me that's not medicine. That is an intervention that's working. And at the end of the day, we want people to feel better, we want people to do more, and we want to keep them out of a wheelchair and off a ventilator.
That's great. One other question is, what can we learn from Pompe for other neuromuscular conditions, such as congenital muscular dystrophy? I know the question's around a treatment for congenital muscular dystrophy, but trying it to another question in the chat box is, what can Pompe teach us about other neuromuscular conditions?
Yeah, Pompe is a little bit interesting because it's not the contractile proteins aren't abnormal, which most of them are in the muscular dystrophies. It's more that they're pushed out of the way because it's a lysosomal storage disease. So the other ones are not amenable to this replacement of the protein. So that's the one thing that's really different. But everything else that I've said about the vitamin D, the B12, the thyroid, the exercise, nutrition, and the creatine across the board for congenital myopathies or muscular dystrophy, those are all applicable. And I think, looking at the benefits of exercise in Pompe disease, that's been shown pretty much with every other neuromuscular disorder. So it does show the consistency of beneficial exercise. And again, you don't want to overdo it. So if it's super intense exercise, you're probably going to damage the muscle. So, stick with those 3 sets of 12 to 15 repetitions, ideally with a certified kinesiologist, or if a physiotherapist really has an interest in exercise, they may be aware of how to do exercise properly. But I think the one group that is underrepresented as a part of the team are certified kinesiologists who spend 4 years in university and then do a certification program to teach people how to exercise with different disabilities.
That's excellent. I know we're at time, and just before I thank you and close it out, there was a question around the publication that you had in 2016, and it was the Pompe disease diagnosis and management, which was published. Is there a more updated guideline for management of Pompe in Canada, or plans for an updated guideline?
Yeah, that's a good question. There is a plan to update that because obviously now there's new things that are coming out. With the new enzyme replacement therapies and such, I mean, the diagnosis is pretty straightforward, and that's pretty much the same. The interventions in terms of exercise, nutrition is pretty much the same. We'll just have to add in those new the data from the AVA study and the Amicus product as well.
Excellent. Well, thank you again for an excellent talk, for a very informative talk. Thank you for taking the time to answer questions of the participants on the line today as well. We welcome you all to attend our next Let's Talk NMD webinar, and have a great weekend. Take care.